Am I on? Okay.
اتفضل دكتور احمد.
السلام عليكم.
عليكم السلام
ورحمة الله وبركاته. Thanks, Dr. Yasser, for the nice introduction, and I'm sorry again for the technical glitch that I had. Hopefully, it will not recur, inshallah. I'm privileged and honored as moderator for continuation of the second session of FSGS. We're today entitled to continue on with the prognosis and treatment of FSGS after we've gone last time with Professor Wissam Ismail through the clinical presentation and the pathogenesis and the pathology. And we do that by presenting 6 cases of real life scenarios of our patients. And we're going to continue on going through the scenario of the patient, different types of FSGS. We haven't, just to recap things again, we've classified FSGS according to patients into S as consumer FSGS. It's to the permeability factor, which is not yet proven to be what one is cardamine there, and it is proven by the recurrence early on after transplant. A very nice case presentation that we've presented the last time we did patient as biopsy and the recurrence was proven by the renal biopsy as well. They nephrectomized the kidney from the transplanted patient, put it in another patient who was a diabetic patient, and the FSGS did not recur in the diabetic patient, and they rebiopsy the kidney again, showing proved that it was the serum of the patient, not the kidney itself, that carries the cause of the permeability factor, which was not yet dealing with FSGS. Its mutation encoding for the protein, and we've mentioned the last time that it is more than 50 gene at least isolated, and this makes the identification because usually what happened is that you don't know which gene is, so you have too many genes, and this makes things much more difficult. With APOL1 FSGS is a specific genetic FSGS, very common in America, and we presented a case that turned to be APOL1 FSGS by reviewing the ancestry and by the biopsy that was proven to be collapsing FSGS. We're going to look for the outcome of that case. Adaptive, infection-related, and drug-associated FSGS are all secondary forms of FSGS. The mechanism of them is all alike, which is the podocytopathy that occurs either by toxin, over the nephron, a functioning nephron, or in from the functioning nephron. And the clinical history for these different types of FSGS is distinct, and this helps a lot in differentiating primary FSGS. Is usually an acute onset of full type of full-blown picture of nephrotic syndrome with heavy proteinuria, hypoalbuminemia, nephrotic edema, whereas genetic FSGS usually having a familial origin, and it is more or less like FSGS of less nephrotic presentation. The APOL1 is usually looks like RBG duration of the kidney, and the kidney biopsy very useful in differentiating the prime from the secondary and genetic FSGS. The EM, when it shows more than %, if this signify FSGS usually, so it can help. Why this is important? Because there is significant difference in the management of the different types of FSGS, whereas this relies mainly on immunosuppression. Secondary and genetic forms do not. Or in other words, it's preferable not to immunosuppression to genetic nor to secondary FSGS. This is not the thing. Other issue, recurrent FSGS in kidney transplanted in primary, not common in FSGS, in genetic, neither in the secondary, unless the causative was not properly treated. It might be difficult to control. I hope that you are all following. Please give me a clue. Okay, and the slide is well shared. Is it okay, Dr. Yasser?
Dr. Ahmed, the slides are well shared, but there is a problem with the voice. If you can get a better connection, will be great.
Okay, there's a problem with the voice.
Yes, your voice is interrupted. If you can get a better connection close to the source, for example, or a data connection will be more than great.
Okay, I'll try to do that. Okay.
You can. Okay. Thank you.
Oh, okay. Whenever is it okay now? Is it now?
Okay.
Are you following, Dr. Yasser? Okay.
Yes.
So
okay. Go ahead.
So when we go for the risk factors for progression, this is very important for the prognosis of the focal segmental glomerulosclerosis. The clinical presentation or the clinical feature at the time of the biopsy, if it is nephrotic range, impairment, or black race, this carries bad for the prognosis of the progression of FSGS. During the course of the disease, if there is failure to achieve partial or complete remission with immunosuppression, if it is primary FSGS, or if the hypertension is difficult to control, this again is a bad omen for the progression of FSGS. With the histopathology, collapsing variant carries the worst prognosis. The incidence or the amount of tubulointerstitial fibrosis, especially if it is more than 40–50%, carries a poor prognosis. The mesangial IgM or C3 deposits are controversial. Most of the studies states that they do not carry a poorer prognosis, and they do not differ whether they are present or absent, either one of them or both together. They do not differ with the state. These are the risk factors for FSGS after kidney transplantation. We're now recapitulating the prognosis of focal segmental glomerulosclerosis before going hand with the treatment. If a patient has a childhood onset with initial kidney of the initial disease, is more likely to rapid progression of the in less than 3 years. It's more likely to recur earlier. Initial steroid sensitivity in children with primary FSGS, again, although difficult to understand, but it carries bad prognosis for recurrence. White African American donor is more likely to recur. The loss of previous allograft due to recurrent FSGS, that's why usually second transplant in a patient who had the previous recurrence of FSGS carries more than maybe 65% or more risk of recurrence, and the third transplant is much beyond the 90% recurrence, so it's almost contraindicated. Patients receiving live donor grafts, and we've mentioned this issue, although live donor grafts had a longer life outcome, but they had higher incidence of recurrence than the cadaveric graft in FSGS. And severe hypoalbuminemia at presentation, and the absent family history, because this goes more with the primary FSGS rather than the genetic. It's a factor for recurrence after kidney transplantation. This is an important part in the prognosis of a patient with FSGS, that should he or she be transplanted or deferring transplantation, going to dialysis because the risk of recurrence might be higher, and so on. And just to mention that patients with FSGS given attention to the quality of life of the patient, maybe as we see in the fourth to the cost burden, and because FSGS is treated with significant morbidity. For example, this study, which is a recent one, just looked at the patient-reported health-related quality of life measures in patients with nephrotic syndrome, both in children less than 18 years and in cases for the physical, social, and mental health, and that they do have a high incidence of health-related quality of life troubles, mainly related to the edema, and next to the immunosuppression that they are receiving, which causes main burden of the quality of life, and so mental as well. Not that only, but also the cost of managing patients with FSGS in the state, whom 2005, and they were 1/3 FSGS and 1/3 non-FSGS. See that the mean total cost was much higher for FSGS, not FSGS, and the health cost related or resource utilization, both in the outpatient visit and in the inpatient stays, was much higher again in the people with, and this was even when patient into nephrotic and non-nephrotic FSGS, with nephrotic non-nephrotic FSGS. So primary FSGS with the nephrotic presentation, with the severe edema, with the hypoalbuminemia, causes recurrent admission, causes more frequent visit hospitals, and definitely causes additional cost in management and treatment and investigation, not only to the patient, but to the healthcare system. So we have to be with FSGS, and the treatment of those patients should be categorized according to the presentation, to what is expected from the patient, and what is the healthcare related quality of life and the healthcare related utility for those patients. Again, are you following? The voice now clear, Dr. Yasser? Hello?
Yes, Dr. Ahmed, it's clear.
Okay. So we're now moving to the general consideration for managing a patient with FSGS. Please, focal segmental glomerulosclerosis is not a disease that everyone should receive immunosuppression. It's not minimal change disease where you start by giving steroids for every person. The first thing to do when you have a patient with FSGS is to try to categorize the patient, whether you should avoid immunosuppression or not. And in any patient who is non-primary FSGS, please avoid giving immunosuppression to those patients. There are some situations also, even in primary FSGS, that you should avoid giving immunosuppression, and we'll mention that. Then you should consider the individual factors like the age, the current GFR, and the comorbidities. If the patient is secondary or genetic, you should go for the just the conservative pathway, restriction, strict blood pressure control, weight loss, and control if any, like in zygoreteric reflux, if massive obesity, if you can treat viral infection, stopping of heroin, and like pamidronate and others, do whatever you can do. And the thing is, you can achieve outcome with these conservative measures. You can keep the kidney for years and years without immunosuppression, without adding to the poorer quality of life of the patient, without adding to the cost, and with preservation of the kidney function. Please do not treat patient without nephrotic syndrome, because if the patient is not a nephrotic, unlikely to be a primary FSGS, and hence there is no need for immunosuppression. I mean, do not treat by immunosuppression, of course. If the patient had the normal renal function, and is not nephrotic, they usually have indolent disease and they will spontaneously remit, usually, or at least they will remain stable for years. So you don't need to treat them. If the patient had increased renal function, so it might be secondary FSGS or a past or a form of primary FSGS that is now more like chronic GN. And in this situation, immunosuppressive therapy will not give a good response. And definitely, if you had a scarred kidney tissue in the histopathology, that's why we only look for in histopathology. We also look for the quality of the kidney, how bad or how good is the kidney, how much is the glomerulosclerosis, and how much is the interstitial fibrosis. And if there is advanced glomerulosclerosis, global glomerulosclerosis, and interstitial fibrosis, massive treatment. So let's go through to our cases, back to our cases. And I will start with the last one, the case number 5. Just to remind you, this was a 19-year-old female patient presented with severe hypertension, anemia, heavy proteinuria, and rapid deterioration of the kidney function. Did many dialysis sessions, and in between she received pulse steroid, and a biopsy was done that was not conclusive, although suggested having an HUS. So she had already presented to us. Her creatinine was very high, proteinuria was in nephrotic range, and her urine analysis showed some microscopic hematuria with negative immune marker. And because it was unclear and the biopsy was not conclusive, we decided to repeat the biopsy. When the biopsy was repeated, it showed that it is an FSGS pattern, but unvaried glomerulosclerosis and 30 atrophy. Of course, we had a problem here. First, the patient had received over the previous 3 months many immunosuppressions with no value at all, and they added to her morbidity. And we stopped all immunosuppressive agents. We put her on a regular dialysis program, and we control her blood pressure by 5 agents to the maximum. The issue was why, as we mentioned earlier, why a 19-year-old female who was not HIV positive, was not an IV heroin addict, and did not suffer from a recent COVID, she had parvovirus or EP virus, all this was tested for her, and it was all negative. She did not receive any drug. She was not obese. She had no vesico-ureteric reflux, no obvious cause for secondary FSGS, and the collapsing type, as you know, can occur with HIV, with heroin, and maybe with COVID-19 lately, but she was not any of these. So when we revise the literature, we find it could be associated with APOL1, as we mentioned last time, although the patient was very fair skin and not an African by any mean, but it was proven by the family history that her grandmother was an African patient, and she had the gene. Of course, we did not test for the gene, but she had the gene transmitted for her through her grandmother, and this was found in the literature. People with recent ancestry from African persons can still present with the APOL1 nephropathy. And magnitude of the disease in patients with one disease, as you can see, 4 in 10 Americans have kidney, African American on dialysis have kidney failure because of APOL1 disease, and it's very common in the population. Just have a look, when you correlate the graphic and immunotherapy in this nice visual abstract, that immunosuppressive therapy can give better renal survival in a subgroup of patients with both nephrotic range proteinuria and hypoalbuminemia, or even in patients with hypoalbuminemia alone. That's why hypoalbuminemia is a more important clue for the treatment and for the follow-up of the in those. There is no improved renal survival in the whole cohort or in the patient with nephrotic range proteinuria alone if they don't have hypoalbuminemia. That's to say, if they are not nephrotic syndrome. So we don't treat alone upon the presence of proteinuria, even if the proteinuria is above 3.5 grams per day. So let's move to a patient. This patient was a 34 years old male. He presented to us nephrotic syndrome with hypoalbuminemia, with normal renal function, with negative immune battery, and the biopsy showed FSGS not otherwise specified, with more than 80% effacement of the food processes of podocyte on electron microscopy. And that's why we were confident that this patient is mostly primary FSGS. He was started immediately on steroids, and he responded excellently to 16 weeks of oral prednisolone of 1 milligram per kilogram per day. The patient was almost 90 kilos, 80 daily of oral pred, and this is the maximum that you go for. And after almost 4 months, his proteinuria came down from 14 grams to 0.5 grams. And he started on tapering, and he is still on tapering. Alhamdulillah, so far he did not suffer any relapses, hopefully to continue on. And this is the guidelines for the initial immunosuppression in a patient with FSGS, primary FSGS, used for 2 to 4 months, and you should taper on another 4 months, and you have to be on extended regimen, not like in minimal change disease where you can treat only for 3 months, 12 weeks for even for adults, and 8 weeks for children. The response of proteinuria of corticosteroid is the predictor of renal survival. So this is a good presentation for a case that is responded, although they are not a lot, those who respond initially. Another patient who had again diabetes, and he had at the time of presentation full-blown nephrotic syndrome with renal impairment with a creatinine and GFR of 16, and he was started on oral prednisolone. Unfortunately, he did not show a good response. Cyclosporine was not amenable because of his very low GFR. He was started on MMF because cyclophosphamide was not available, the oral form at that time. MMF showed a good partial improvement initially, but the patient 1 month later, again, he recurred with heavy proteinuria up to 15 grams. Okay. Okay, salam alaikum, and sorry, internet, the Wi-Fi in Alexandria nowadays is very poor signal. I'm sorry. Now we were lost when we said that we were forced to give MMF because the patient did not respond to oral bread, and the cyclosporine was not feasible because of the low GFR. He initially responded, he recurred again. After a while, the patient managed to get oral cyclophosphamide, and I would like to discuss this point after the lecture with our esteemed professors and guests and moderators of any experience of giving IV cyclophosphamide when you are not able to give oral cyclophosphamide in the situation that's stable, not IV. And we can discuss this point at the end. Patient was late for like 2 months till he got an enough dose of oral cyclophosphamide, and he was started on 150 milligram per day. He showed marvelous response both for urinary ACR, which now is almost less than 1 gram, and his serum creatinine that gradually dropped to 1.6 milligram per day. And this comes to the corticosteroid resistant FSGS. The first option is a CNI, with or without lower dose of steroid. MMF comes as a second line. If the patient has a steroid resistant FSGS, cyclosporine is the most effective to induce remission, and it should be used for a long time. And discontinuation of the cyclosporine should be very gradual tapering after attaining a remission, whether partial or complete. It states like you at least should go on for 1 more year after the remission. And the use of tacrolimus when cyclosporine is not there, but as well some improving of the remission rates if cyclosporine failed to do so, but unfortunately very high rate of recurrence upon discontinuation. On the other hand, in patients who are steroid dependent or frequent relapsing, you can use again cyclosporine, MMF, and usually the MMF is chosen for those patients who had a lower GFR, with the GFR below than 30 milliliter per minute, and maybe even we don't have the gut to give cyclosporine for patients with a GFR of even higher values than this, like 40 per minute for the progressive nephrotoxicity of the cycle. Detoxing situation, and it's been increasingly used for steroid-resistant FSGS. You know that rituximab is being used for some beyond its immunological background. It's being used in minimal change, where minimal change is not a CD20 mediated disease. Definitely, it's used in membranous, and this is understood. It's used in FSGS, but we'll come to this point later. Several retrospective observation studies, there is no RCT, they show good remission rate up to 41%, although they were in the most small studies. Relapsing steroid sensitive nephrotic syndrome, oral cyclophosphamide in a dose of 2.5 milligram per day for 2 months, compared to cyclosporine in a dose of 5 to 6 milligram per kilogram per day in 2 divided doses for 9 months, they showed similar relapse rate after 9 months, but significantly less relapses with the cyclophosphamide than the cyclosporine group. And please note that the doses are a bit higher than the usual. For the cyclophosphamide, we usually use 2 milligram per kilogram. Here it's 2.5. For the cyclosporine, we usually use 4 milligram per kg. This is 5 to 6 milligram per kg. For relapsing FSGS, again, after achieving complete or after achieving partial remission, of course, when you achieve complete remission, the relapse rate is usually less, maybe 1/3. With the partial remission, it's up to half of the patient can relapse. They have poor renal survival when they relapse. If they had got a good initial response to steroids and no massive side effect from steroids, the first thing to do is to repeat the course of steroids instead of using other immunosuppressive agents. If this is not feasible, you should go for a CNI-based regimen or an MMF-based regimen, as we mentioned before. That maybe there is an add-on effect beyond the immunosuppressive or the immunomodulating effects of agents. For example, the hemodynamic effects for the cyclosporine. Rituximab was shown to directly affect podocyte function using this SMPDL dependent manner in cases of recurrent FSGS. So there is something behind the immune mediated mechanism there is for some agents. Of course, anticoagulation for nephrotic patients is classically mentioned for membranous nephropathy when the albumin level is below 2.2 per serum. But in cases of heavy proteinuria with severe hypoalbuminemia in patients with primary FSGS, it warrants to give prophylactic anticoagulation as well. These novel therapies actually are points for discussion. The abatacept, as you know, have been used for kidney transplant for a long time, and there is no actual strong data to support its use, but it has been tried. The sparsentan as an endothelin receptor and has been used as well. It's not in routine use so far, but it has been used in trials. The plizilumab, again, is being used for kidney transplant with recurrence, with the fear of recurrence of FSGS post-transplant. It has been compared whether you give it with MMF or you give it with TAC. And when you give it in a study with MMF, there was an increased incidence of rejection. And when it was given with TAC, it was non-inferior to the standard care, which is the triple immunosuppressive called Prograf, MMF, and steroid. It shows some decrease in the recurrence of FSGS post-transplant. The frisolumab, again, is an anti-VEGF, TGF-beta with all the isotypes 1, 2, and 3, and it has been used in many of the fibrogenic diseases, not only in the FSGS, but also in lung fibrosis and others. Again, there is no solid data to, it's just an investigational drug so far. And this is an interesting point. The PODO trial with this PF0673, as you can see, the number of the investigational agent, which is being developed, I think, by us. It's just a ROBO-SLIT immunoglobulin inhibitor. It's an antibody directed toward the roundabout portion of the podocyte slit interacting or slit diaphragm interacting molecule, where it this genetic mutation causes the proteinuria and the heavy proteinuria nephrotic syndrome. And this agent has been developed as an immunoglobulin fraction that specifically bind to this roundabout podocyte molecule and causes its inhibition of its action. So in these two open label trial, which is under trial, biopsy proven FSGS. Unfortunately, through the paper, they did not mention whether those patients were only primary FSGS or they included genetic and other forms. The inclusion criteria was a GFR more than 45 milliliter per minute and the proteinuria more than 1.5 gram per gram, which means that definitely some of them were not primary, because primary usually would have a higher proteinuria. And of course, they all would have a recent biopsy proven FSGS. And they divided the patient into two groups, high dose or low dose. They received the shot of this investigational drug IV every 2 weeks for 12 weeks. and they reassess the response by the safety first. They excluded patient with transplantation, patient with active infection, patient with malignancy or concerned with malignancy, and they assessed primary the urinary protein creatinine ratio at the week 13 after finishing 6 doses of the drug by a week, and they assessed secondarily the changes in the GFR and the serum level of the drug. This trial is ongoing, and they say that they have a proof of concept that the drug can be used to, or propagated to phase 3 clinical trial, and we are awaiting whether we're going to find any benefits from that investigational agent. Lastly, I would close by mentioning that plasmapheresis is actually of very limited value in managing primary FSGS. It's not a choice to diagnose a patient with primary FSGS and treat him by plasmapheresis. Whereas in transplanted kidney, there is a conundrum of that like you can scientific a fact taking me of this further by, and this if you did that early on, just after the discovery of the recurrence of FSGS, which would be by measuring the proteinuria serially and with the early appearance of proteinuria in the urine of the patient who is recently transplanted, you can institute plasmapheresis. It has been mentioned that in trials, this can delay the recurrence, but unfortunately, this might be temporary, and the proteinuria will recur again after 2 months from stopping the plasmapheresis. So again, whether to use it or not, I think last time Professor Ayman Rafai mentioned that they stopped doing that in Mansoura after trying this for a while. So it's again an issue that might not be of value anymore. Definitely not for the primary disease, but maybe for the recurrent after transplantation of a primary FSGS, and maybe not. And by this, I would thank you. And again, I would apologize for the technical, and I hope that we can discuss whatever can be there over the next few minutes.
Thank you, Professor Ahmed, Professor, for this highly elegant talk, and we enjoyed it in spite of technical problems. Professor May, please.
حاول تجي الفيديو. دكتور أحمد مش عارفة أفتح
stop share أنا.
الفيديو. Okay.
Okay.
You cannot start video because the host has stopped it.
Okay, now.
Okay. Professor Ahmed, thank you very much for this elegant and informative lecture. Actually, you touched many aspects, almost all aspects of treatment of FSGS. You made it very clear that immunosuppression should be given only in primary FSGS. Maybe cyclosporine can be given in genetic forms because of its local effect on the podocytes, not as an immunosuppression. But you mentioned not to use immunosuppression, and correct me if I'm wrong, if the patient has non-nephrotic range proteinuria, even if primary FSGS. Is that right?
Yes, that's right, Professor May. The issue is, it's likewise in a way, those patients with membranous nephropathy, that they have an incidence of 40% spontaneous remission within a year if their proteinuria is below the nephrotic range or maybe below 4 grams or so. So we can give those patients a trial of spontaneous remission if the proteinuria is below nephrotic range, even if they were proven to be primary FSGS.
Do you think that it usually succeeds, this style of remission?
Well, I can say that I have a lot of those patients. Actually, most of our patients would present with heavy proteinuria and very, very blown nephrotic picture.
How the primary is, yes.
Yes, the primary usually like that. Yani maybe those patients went unnoticed in the most.
Okay, another thing you mentioned, not to use immunosuppression in those with significant reduction in the GFR, less than 30, not to start. Is that right? Because I think here there are exceptions, right?
Yes, this is another issue again. Of course, it's not the absolute GFR value. It is the progression of these GFR. I mean, simply it can be an AKI secondary to renal impairment.
Exactly. So the rapidity,
yes,
the duration.
Yes, our second patient that we mentioned, he actually had a GFR of 16 milliliter per minute, but most of these was secondary to the AKI in nephrotic patient with the severe hypoalbuminemia, and with the correction of this situation, definitely the GFR can improve, and then you can go on.
So if the patient has long-standing FSGS, then probably this will not work with the GFR that low. But if it's a recent FSGS, then it could, especially when the biopsy shows no evidence of
yes, fibrosis and glomerulosclerosis, definitely.
But you have a question here on the use of your patient, the second patient, of cyclophosphamide 150 milligram daily. It says, is it not high, especially with the GFR 15? And this is a discussion from Khalid Abu Zaid.
Excuse me, to add to this question, I'm asking also, in addition, if the dose of cyclophosphamide 5 to 6 milligram, is it not high for glomerulonephritis, in addition to the mentioned question by Dr. Khalid Abu Zaid? Dr. Ahmed, are you following?
Yes. Yeah. Can you hear me, Dr. Yasser?
Yes. Yes. You can hear you now.
Okay. Yes. Yes. The issue is the use of cyclosporine. If I got the question right,
the use of cyclophosphamide.
No, cyclophosphamide. Yes, cyclophosphamide. So cyclophosphamide with a lower GFR, what we used to do is to reduce the dose to 75 milligram. 75% of the initial dose. I mean, if you're going to use like 100 milligram, you would use 75 milligram instead of 100 milligram if the GFR is below 30 milliliter per minute. But then it carries no nephrotoxicity and it can be used. But again, if this reduction of the GFR is a permanent reduction due to bad kidney, it's not wise to use it.
So you try it in a good kidney, pathologically?
Yes.
Okay.
Professor Ayman Rifai wants to comment, Dr. Ahmed.
Thank you very much, Professor Ahmed. And this was a very clear presentation, actually, and he addressed several important, crucial issues in the management of focal segmental. And let me start I totally agree with you that not every case of FSGS should receive immunosuppression. We should categorize first, and before we are going to or decide to immune suppress them. I want to emphasize also that most of the cases of steroid-resistant focal segmental, steroid-resistant minimal change are really cases of focal segmental glomerulosclerosis in their early evolution. And when we rebiopsy these cases, we discover that these cases are focal segmental case, not minimal change.
Yes.
One point I just to add on the risk factors, the list that you addressed in for recurrence focal segmental after transplantation is the presence of mesangial proliferation in the biopsy. I think this is a very important issue that we should read the biopsy details very carefully. And whenever there is mesangial proliferation, there is high instance of recurrence after transplantation. Another two scenarios that we usually are in dilemma in these cases. When a case or end-stage renal patient who is seeking for transplantation, a transplant candidate, and came with a biopsy of the native kidney, the focal segmental glomerulosclerosis. We should differentiate, and I think we need to differentiate between this is a primary focal segmental or this is the focal segmental picture that accompany end-stage renal disease. I remember we were confronted with one patient last week that he had a biopsy with Professor Wissam, and I called her, please, the final diagnosis was focal segmental, but I think we should go through the details of the biopsy to see the tubular interstitium, the chronicity, and this is very important before we can stamp him as a focal segmental case that we are fear of recurrence and so on. So we have to take care about the biopsy of end-stage renal disease that came with the diagnosis of focal segmental. I think this is not the primary focal segmental. One last issue is the when to withdraw or stop cyclosporine for cases who responded very well to and remission was induced successfully in such cases. With our experience that when we withdraw such patients or stop cyclosporine and they have a relapse, we will never succeed to induce remission again, even after reducing cyclosporine. So I think so far there is no side effects from cyclosporine, no hypertension, the kidney function is perfect. And even if we go further to do a biopsy to be sure that there is no interstitial fibrosis or any cyclosporine toxicity, I think we better to keep him on cyclosporine even on a low window between 40 to 80
even at a low dose. Yes,
is a low dose is better than stopping this. Consider, let's consider it as a transplant patient who will live lifelong, but usually the relapses could not be remitted again after withdrawal or stopping cyclosporine. Thank you very much, Professor Ahmed. It was very clear and valuable presentation, actually.
Thanks, Professor Ayman. Wallahi, yani, mashallah, very, very nice points to be mentioned. وكل واحدة فيهم is a separate lecture by itself. As far as the point of the whether is the recurrence or the FSGS in the transplanted kidney is a recurrence or a de novo FSGS, which can be de novo glomerulonephritis or de novo adaptive form due to failing graft. I think the main issue is the time of recurrence. The early recurrence after few hours to few days with transplantation of proteinuria documents that this is a recurrence of the primary FSGS. Then the kidney might fail after a few years later, but the early recurrence of proteinuria post-transplant, that's why it's important in any patient with transplantation secondary to FSGS should have serial proteinuria check with the check of the renal function and the Doppler RI and everything else. The next point is the cyclosporine. Yes, exactly. That's what we are doing in our real life scenario. And I would mention a few things that I think it's not, it has no solid scientific background. But what we usually do is we keep the patient on very low dose of cyclosporine, like 25 milligram of Neural twice or 50 milligram twice, and let the patient taper by himself, to play with the dose. And then you ask the patient every now and then, how much compliant are you to the dose? And then, with time, patients start to be more reluctant when he found himself in a good shape. And by this situation, you can assess that even a patient with a very low dose, sometimes down to 25 milligram once every day or every other day can be sufficient to prevent recurrence. And for this situation, you can keep the patient like this. I'm not saying this is a scientific approach, but this what happens with a lot of nephrologists, and we leave the patient. I mean, this dose is not harmful to the kidney, and you're in a way or another not afraid from recurrence as long as it's doing fine. One last thing, I just read the question of Dr. Khaled Abu Zaid. He was asking about that 150 milligram of cyclophosphamide is high dose. Actually, no, the patient was 100 kilogram, and the dose should be at least 2 milligram per kg. This is the proper dose of cyclophosphamide, and even in FSGS in some trials 2.5. So he should receive 200 milligram per day. Because of his renal impairment, he received 75% of the dose, which is 150 milligram, and that was quite beneficial for him. Thank you.
Excuse me, Dr. Ahmed, to catch this point and to not miss, do you think that the dose of cyclosporine 5 to 6 is not also high in case of GL?
It is very high to me. I have never used more than 4 milligram. Actually, I even usually in GN don't go to the 4 milligram. Usually I'm around 2 to 3 milligram, and maybe escalating gradual to find out the responsive dose where it is.
But as I remember, you mentioned it is 5 to 6.
No, this was the study. This was one study that compared cyclophosphamide of 2.5 to cyclosporine of 5 to 6 for 9 months for cyclosporine and 2 months for cyclophosphamide, and both arms were higher than the usual.
Yes.
Thank you for clarifying
but
this
in
point.
the general practice, it's the steroids that should be high, but the other immunosuppressive should go along the same doses that we know of, right?
Yes, yes, shukran, Dr. May. And this point I want to emphasize again, because I have recently encountered a patient that was on 160 milligram of steroid daily. And this dose has never been mentioned anywhere. So we should overstress that the maximum dose of steroid is 80 milligram per day or 120 milligram every other day. Not ever not more than this. 1 milligram per kg, maximally 80 milligram per day or 120 milligram every other day. And please do remember that P for prednisolone stays for poison. Don't take it easily.
Okay. Professor Said Khamis wants to comment. Professor May.
Dr. Said.
شكرا دكتور مي. شكرا دكتور ياسر. Thank you, Professor Ahmed, for the elegant presentation as usual. Just I want to ask about the statins in such patients for treating hypercholesterolemia, and in the meantime, regarding the PCSK9 inhibitors, the safety and efficacy in such patients, especially the nephrotic syndrome, they found that the level of this PCSK9 is high. I know it has nothing to do with this filtration barrier dysfunction, despite it is correlated with the proteinuria and the remission of the nephrotic range of proteinuria. But I mean, as a treatment for hypercholesterolemia, what is the efficacy and safety of this PCSK9 in such a patient? And thank you so much.
Shukran, Dr. Said. Thanks for the compliment, and it's very, very practical and in-depth question. Regarding the statin, yes, definitely we use a statin with dyslipidemia associated with nephrotic syndrome. Although the use of statin here should be again subject of the level of cholesterol and or triglycerides, because usually what happens is with control of proteinuria, if the patient remits, usually the level of the lipids goes back to the normal and you can stop statin. For the PCSK, as you know, it's not a primary treatment, it's an add-on treatment if you do not reach the target by statin, and I'm not aware that patients with nephrotic syndrome are resistant to the action of statin to the extent that they can use the PCSK inhibitors. And of course, I have never used it in nephrotic syndrome patients. I don't know whether there is an added benefit or not of its use.
Yeah, thank you so much.
Thanks.
Dr. Ahmed, what I want to ask you about is, we know that it's not advisable to stop cyclosporine altogether, and we can see that in our practice. The question is, when to stop steroids if the patient has incomplete remission? So what do you think?
Well, incomplete remission is a difficult point to define, as you know, Professor May. Let me answer the other question, which if the patient has a complete remission, which is more easier.
Okay. I'm asking this question because I see patients going on immunosuppression.
Yes, I understand.
Indefinitely.
I would say that with complete remission, the literature says that you take it for 4 months, 16 weeks, and taper over another 4 months. So it will.
Ahmed, we cannot hear you.
Can you hear me now?
Yes.
Okay. So if the patient is in partial remission or incomplete remission, the issue usually would be that if this is a good partial remission, that's to say proteinuria below nephrotic range with normalization of serum albumin, it can be treated like complete remission. Knowing
Dr. Ahmed?
Yes. Yeah. I was just saying that not to keep the patient on long-term steroids because you're not going to gain any more. So if it is good partial remission with normalization of serum albumin and proteinuria above 1 gram but below 3 grams, so what I would do is to do the same like incomplete remission and taper over another 4 months.
Okay. Good.
Professor Ahmed wants to comment.
I just want to emphasize that the trial of shifting cyclosporine resistant cases to tacrolimus, I think this is not a good policy. From the practice and from the literature, patients who did not respond to cyclosporine will not respond to tacrolimus. So shifting to tacrolimus, I think this is not a successful policy and time consuming and cost effective. I mean, it's costly for nothing. And even there is cases who develop renal deterioration of the renal function after starting tacrolimus without any benefit. So this is a good point that.
Yes, I think you're absolutely right, Professor Ayman. Even they showed only 15% initial improvement with 75% recurrence rate, much higher relapses.
Yes.
I think
the problem of cyclophosphamide, oral cyclophosphamide, is the unavailability rather than the adjustment of the dose and so on. It's not available in Egypt, the oral cyclophosphamide. That's why we are obliged to have the IV form in these cases.
This is a very important point بقى حضرتك I alluded to during the presentation, and I really want to discuss this. Not only for the FSGS, but even for the Ponticelli, for the Ponticelli regimen. Whenever oral cyclophosphamide is not available, because I came through maybe 1 or 2 papers that are using IV cyclophosphamide alternatively for oral cyclophosphamide in fractionated doses. I've done that with few cases using IV 200 to 400 milligram per week IV according to the body mass index or the body surface area of the patient, instead of using the oral form because the unavailability. But I don't know whether this is a good practice or this is, and I don't have data about this. So can we discuss these points?
I think there is no supporting data for such protocol, but you depend on your clinical sense and experience. يعني it's اجتهاد يعني we are just لكن we have some patient that they have access to have it from abroad, from Germany and so on, and they responded very well actually after adding the cyclophosphamide oral, especially of course in membranous cases. But I don't know why it is not available in Egypt. This is a cheap drug. It was available before. I don't know what's behind the unavailability.
Was available
recently. Recently أنا عرفت من بعض patients that they can get it from the main central pharmacies of شركة الجمهورية and others, but they gave them like one blister by one. Like every 10, for example, days, they have to take another few tablets. يعني it's difficult. يعني.
Do you think, Dr. Ahmed, that oral cyclosporine or TAC represents a good option in this case, especially in membranous and FSGS? I don't speak about, of course, something. Dr. Ahmed, can you hear me? So, Dr. Ayman and Dr. May, Dr. Saeed,
I can hear you. I can hear you. Yes.
In this case, can we jump in case of membranous or of FSGS to oral TAC or cyclophosphamide? Will be a better alternative.
هو يعني I wouldn't go for that. It is better, but it is available. لكن يعني for example. Some people definitely for the membranous do not respond for the CNI, and they do good with the Ponticelli regimen. So it's again, the main issue with the CNI is the level of the kidney function. If the GFR is below 30, and for myself, I don't like to give it below 40 or 45 milliliter per minute. I feel it's the kidney is not so good to give a CNI in this situation. So cyclophosphamide would be your only option.
I feel for me I feel that my main concern issue is the fertility. Most of our patients are in the fertile regions, and you know the high toxicity of oral cyclophosphamide.
So of course you have to weigh all things together. But if you have impaired kidney function, sometimes you will not be able to receive calcineurin inhibitors. So you will need the cyclophosphamide.
The other thing, Dr. Yasser, regarding this, that if you remember when we met maybe a month or a couple of months ago, we spoke about the fertility preservation technique for immunosuppression patients. We can do that easily, and we should encourage. Thanks for arousing this point. We should encourage sperm preservation, cryopreservation, ova cryopreservation, or even embryo.
It's very underlooked, this point, really.
Yes, we should go for that. I mean, whenever you know that you're going to give the patient cyclophosphamide, tell him just go and preserve your sperms or your ova, even if not married, or do a sort of ICSI and preserve embryos if they were a couple. And this should be a good standard of care to be done for those patients.
Thank you. We have some questions in the chat. Professor Mike, can you read?
We have two questions on the use of permeability factors. Can the permeability factors be included in the risk factor for recurrence of FSGS in the allograft?
The issue with permeability factor, Dr. May, as you know, it's not settled yet. It is accepted that there is a permeability factor, but what it is it the SUPAR, the soluble plasma activating receptor inhibitor of whatever, or the cardiac troponin, or is it the ApoB1? Many have been suggested and no proof yet, so we don't know what to measure.
And this answers the second question. Are there any permeability factors proven to be included in the pathogenesis of FSGS? As all mentioned in the textbook are debatable, so they are still debatable.
They are.
We don't have a permeability factor that we can follow for prognosis, for instance, of risk of relapse or any like in the membranous GN. So we still don't know what is the permeability factor to follow.
Yes.
I mean, I want to ask about the recurrent FSGS, and the question is to you, Professor Ahmed and Dr. Ayman as well, about the use of plasma exchange. So apparently there is no benefit of pre-transplant plasma exchange for those with FSGS primary. But for the recurrence, I think it has a role. And yes, if you stop it, it can recur, but some people continue on plasma exchange on regular basis, monthly or every few months. So what do you think, Professor Ayman?
I totally agree with you, Professor May, that plasmapheresis post and recurrence post-transplant have a rule, and this is I think the most effective or the most efficacious treatment for recurrence. The problem that we don't know for how long we are going to do plasmapheresis, but I think what we are practicing, that once the proteinuria achieved below the level of nephrotic range, we keep the patient once weekly, twice monthly, or whatever, just to keep this low proteinuria to continue. So for how long, no one can say that.
We don't know.
But it's effective. We don't know, yes. And I think this will remove the permeability factor or factors that we don't know, and this is the rule of the plasma. So we should keep that. We have patients that came for twice monthly for plasmapheresis and their proteinuria is ranging around 1 gram per day, something like that, with good albumin and no symptoms. When we try to stop and withhold this plasma, the proteinuria increase. So we are keeping this regimen.
There's please stress on the lowest dose of cyclosporine prescribed lifelong. I think you answered this question, Professor Ahmed. Maybe down to 25 milligram.
Professor Dawla Bilal wants to comment.
You hear me, Yasser?
Yes, yes.
صوت واطي شوية بس
They have a protocol in each pediatric hospital in pediatric transplants. Pre-transplanting primary cases of FSGS, they have plasmapheresis and IVIG. This is a regular protocol they use there for these cases. And apparently it's well established and with good results. So there is pre-transplant in these cases with IVIG.
I've listened to Professor Grassock's talk. I'm not sure, but he was mentioning that it showed to be of. I don't know about the pediatrics, really, Dr. Dawlat. Maybe it's there for the pediatrics. I'm speaking about the adults. That its effect pre-transplant is not there actually. It's mainly post-transplant, but maybe for the pediatrics, yes. Okay.
This is a very well used protocol there now.
Yes.
In a breach, and I'm always
sure.
I'm always watching their cases there. This is a protocol they are using here.
And Professor Dawlat, how is the rate of recurrence? I mean, not the immediate recurrence post-transplant, but the long-term recurrence.
Yes, that was mentioned by Professor Ayman, that there is a protocol after transplant. You have to do some plasmapheresis and just to preserve the kidney. This is one point. Another point I want to ask Professor Ahmed, you are restricting treatment when you classify cases to probably the middle group. The first group, which you say we have good kidney function and they have non-nephrotic proteinuria, you just leave them on the assumption that they might recover spontaneously like 30% in primary membranous GN. So you really do that? Is this aided or emphasized by a biopsy of, say, a tip lesion, not another lesion, that you have the courage to not to treat these people?
والله دكتورة مي دكتورة دولة أنا آسف لو if those patients were really non-nephrotic where proteinuria is minimal, I'm not saying we're not going to treat them, but we're going to observe them, because a lot of these people would develop into proteinuria later on.
Any correlation to pathology?
To the pathology, maybe to the EM better than the type of the lesion, because even the tip lesion, we had few cases of tip lesion that were aggressive in proteinuria. I mean, it's not so much indolent like we thought. I mean, as a nephrotic range, it can be nephrotic range proteinuria. But if the effacement of the food processes is too much heavy with the primary type of FSGS, and the denudation and the affection of the podocyte is severe, I think this warrants early treatment. That's why EM is important in FSGS, although it can be diagnosed from the light microscopy and from the immuno, definitely by the absence of most of the antibodies or even the presence of C3 and IgM. But the EM is very important in prognostication of the FSGS.
How do you watch them? I mean, what's the point? The degree of proteinuria increasing?
Yes, definitely. The degree of proteinuria and the degree of hypoalbuminemia. And I want to stress a point that in following a nephrotic patient, the normalization of serum albumin is much more important than the decrease in the level of proteinuria. Yeah. Because whenever you normalize the serum albumin of the patient, this means very good response, and the proteinuria will come as a secondary point after that. So we should be very much keen about measuring the serum albumin with the proteinuria each and every time.
Yes, right. So you just keep them carbs and usually they are not hypertensive.
Definitely, yes. The presence of hypertension is an indication for treatment and is a bad news for the prognosis of the kidney. In FSGS, I mean.
And I think in all glomerulonephritis, hypertension is considered a bad risk factor.
Yes.
Especially resistant, yeah.
Yes, definitely.
So if again to transplantation, Dr. Ahmed, would you, in the recurrent form of FSGS, would you start by using cyclophosphamide or rituximab with the plasma exchange? I mean.
This is a very, very difficult question, Professor May. Actually, I'm not going to say this is from a scientific reading, but I feel like using rituximab in this patient would be a double-edged sword. It can help with the kidney, the transplanted kidney, and it can help with the FSGS. And the trials using the rituximab in the native kidney with FSGS are encouraging. to use rituximab in this situation. And one of the good things in rituximab, the after drug effects that we used to hear earlier for some of the antibiotics, that even after stopping the treatment for a long duration, you can still find a response. And these have been shown in membranous nephropathy with the use of rituximab, that the outcome is better after even 6 months of finishing the dose. It's like gradually building up the effect. Using cyclophosphamide, on the other hand, as an addition to the whole cyclosporine and MMF and steroids, I would be very suspicious if it would add any more. But what you can do is shifting, and shifting would hamper the kidney stability. It might go to rejection.
Yes.
So I think rituximab might be a better option.
I think you're right. I think I go with your opinion. Yes. Yes. Professor Ayman موافق على الكلام ده؟
Professor Said Khamis wants.
Professor Said اتفضل.
شكرا. Professor Ahmed, we cannot deny the issue of the adjunctive antiproteinuric effect of this ACE and ARBs and so on. But what about the recently, or rather recently introduced SGLT2 inhibitors and the mineralocorticoids like Proteinuria? Do you have any good effect regarding the proteinuria, especially in this FSGS? I mean, the nephrotic range of proteinuria, deterioration of kidney function, and so on.
Dr. Said, you're always getting the good points and updated points. I didn't like to mention these points because I don't have enough data about. But for patient number 2, who was a diabetic patient and he suffered from FSGS, I actually put him on SGLT2 inhibitor before even putting him on the immunosuppression, before getting the result of the biopsy. Yeah. And I think that it helps a lot with the decrease of proteinuria. I'm not sure of that because he actually eventually received the immunosuppression afterwards, steroids and then cyclophosphamide after the MMF. But if we can extrapolate from the result of the IgA trial, I mean the IgA subgroup with the dapagliflozin, as you know that the IgA group in the DAPA-CKD study was even higher in number than those patients in the STOP IgAN trial. Yeah. So definitely there is a very potential good response with the proteinuria and the control of proteinuria in patients with nephrotic range in those IgA patients with the dapagliflozin. Whether this can be extrapolated to others, I have done that twice. Once with a membranous patient and the second with this FSGS diabetic patient. And in both patients, I've got good response to proteinuria, but I'm not sure whether it is a confounding factor or an added on effect. But it's a good point to be tried.
Okay, thank you so much.
Okay, back to the recurrence after kidney transplantation, especially the aggressive recurrence in the early post-transplant period. Our protocol is to give, beside plasmapheresis, IVIG and rituximab. We succeeded to induce remission in such cases, and the last case was 1 month ago. A 19-year-old gentleman who developed recurrence after 48 hours of transplantation. Proteinuria was 25 grams, albumin dropped to 2, with increase in the body weight that reached 10 kilos above the dry body weight, and after doing the biopsy and confirming the recurrence, we started plasmapheresis, IVIG 5 doses, and rituximab 4 weekly doses. And the creatinine was dropping very slowly. And fortunately, we succeeded with this protocol that he was presented today in the outpatient with proteinuria 0.9, with albumin 4 and creatinine 1.1 with, and he is now on dry body weight, and we are keeping him in weekly plasmapheresis, and this is the protocol. So the aggressive and early recurrence necessitates plasmapheresis, IVIG, and rituximab.
Very interesting, Professor Ayman. And what do you do for the rest of the immunosuppression, the calcineurin inhibitors, and you continue the same doses?
Yes, we are continuing the same doses. So with tacrolimus and MMF and steroids.
Yeah, Dr. Ayman, how about the plasmapheresis? For how long are you planning to keep him on a once weekly?
We are now on once weekly, and our planning that if we succeeded, we will keep it every 2 weeks, and then we are going to withdraw very gradually from plasmapheresis. So far, there is still proteinuria, and now after normalization of the creatinine, we started to be, we were encouraged enough to add ARBs that we
succeeded already.
No.
I think you succeeded already, Professor Ayman.
Yes,
so,
yeah.
You are still giving once weekly? You're still giving once weekly?
Yes, he just finished the aggressive plasma last week. So this is the first week that we are going to give him after twice weekly, once weekly.
Okay. So we have other questions because
there's still some in the chat.
Follow-up of FSGS after transplantation will be only by proteinuria and graft function, or you recommend something else, something more? Dr. Ahmed.
I don't know, but if center is adopting the protocol biopsy, it would be very excellent procedure to be done. But if not, the proteinuria, as Professor Ayman just said in the last case, would be very. The recurrence is usually an explosive one. We've just heard proteinuria of 25 grams and serum albumin of 2 with 10 kilos of water on his body in few days post-transplant. So usually it's an explosive one, but follow-up with proteinuria is the mainstay.
I think proteinuria is enough, Dr. Mail, because when we are doing surveillance or protocol biopsy, focal segmental will be there in each biopsy. It will not resolve. So there is no value to follow up with biopsy so far.
There was this opinion about this because the effacement occurs before the proteinuria, so it's better if you detect it early enough. I don't know about the protocol of doing this protocol biopsy and how often to do it and when to start doing it. أقل حاجة نعملها إن إحنا نبقى taking care of the follow up of the proteinuria very closely.
Suppose that we found it in protocol biopsy just with no clinical.
Yes, it will be there all the time. The focal segmental lesion will be there. It will not resolve. We will find it in each biopsy. But the most important is there is a significant proteinuria or not.
But so if you have a new kidney and if you have a transplant kidney and you look for the effacement, if it starts or not, I think this is also important.
Of course, but follow up with the biopsies in such cases is
maybe only early on.
Maybe. Yeah, but I think we should emphasize that focal segmental lesion is a challenging lesion. So
Yes.
we should put in mind that we are not going to succeed to achieve remission in each case, or always to achieve remission. So I think after a while of trying everything, of steroids, CNI, cyclophosphamide, rituximab, etc., at some point we should raise our hands. There is يعني, to leave him to go in a very good shape, or
Yes.
to go in peace with the end-stage renal disease. We are not going to kill him to achieve remission that will never be achieved. I think
Yes.
so.
And I
This
think
is,
this
this
is
is a point of
this is
wisdom. Yeah.
Yeah,
importance of
this is a
biopsy
very good
in these
point,
cases, and
Professor
follow-up
Ahmed,
biopsy.
actually. Dr. Yasser, sometimes even without biopsy, sometimes really you have to just take off, leave the patient with no further immunosuppression, and another thing is to do is always not to forget to treat the patient as a CKD patient. I mean, you have to remember always to do some moderation of protein in diet, to give sodium bicarb to those patients. I mean, after all, it's a CKD patient, so you can start or stop the immunosuppression for the, I mean, unaccepted side effects with minimal benefit, and start treating a CKD patient and prepare for the progression.
Yes, this is the wisdom of the doctor. Yes.
Yes.
Professor Daula Bilal wants to comment.
Yes,
تفضلي
going
يا
back
فندم.
to the recurrence post-transplant, the recurrence is usually extremely rapid, within hours. So a protocol biopsy here will not. I should have a high suspicious or anticipate that this is going to happen. So having a protocol biopsy, you mean at 0 hour? This is the first protocol biopsy. As Professor Ayman said, the lesion will be there. I think proteinuria is much more practical to follow with, not protocol biopsy.
Okay. Thank you, Professor Dawlat. Now we have a question on the type of machine used for plasmapheresis. I think it makes no difference. What do you think, Professor Ahmed?
There are some studies about the difference between not the machine, but the type of the plasmapheresis, whether or the plasma exchange, whether it is a centrifugal type or a membrane filtration type. Actually, the thing is, in most of the indications, the centrifugal type may be better than the membrane filtration type, but in few indications, as per listed with the ASFA guidelines, the American Society for Apheresis, some of the indication, the membrane filtration and the centrifugal are equivalent. I'm not aware specifically for the FSGS, and this may be because, again, the permeability factor is not well delineated, so we don't know what we are removing. That's why we cannot have a preferential value for centrifugation or membrane filtration, if this is the question point.
Okay. We have another question on the toxic dose of the toxic cumulative dose of cyclophosphamide. Is it 36 grams?
No, this is too high. This is too much high. We used to say 2 grams. Sorry, 12 grams, I'm sorry, 12 grams. And I think we came down to 9 grams nowadays. It's definitely not beyond the 12 grams. Early on, it was said that it is 18 grams, but it's again too much high. I think it's somewhere between 9 and 12 grams, the total cumulative dose.
Very well. I think we have answered all questions, or is there any more questions?
Dr. Dawlat,
Yes.
do you want to add more?
I keep going back to the post-transplant because I see that much, lots of cases in Abu Rish with the protocol, keeping in mind that they are all related donations from mother to child all the time. So in a living in a
So-
FSGS, we should anticipate that we have a
Yes.
high incidence of recurrence in living donation.
Thanks for this very important point, Professor
Yes.
Dawlat. Actually, live-related donation in primary FSGS should be discouraged. Live-related donation in primary FSGS shouldn't be the standard. They should have. Live unrelated is much better, or I mean emotionally related, not biologically related. Both for the patient and the recipient, by the way, for the donor and the recipient, by the way. I think Professor Ayman would tell us that the donors who were found to be a silent glomerulonephritic patient in their cohort were most of them those relative of FSGS patients.
You're right, Professor Ahmed, but this is something you cannot control when it comes to donation in childhood.
Mother and child cannot.
Yes, I know that. I know that.
Okay, let me ask you the last question بقى عشان احنا بقى Tell me what are the indications for genetic study? When to think about doing genetic gene study?
You mean in FSGS or in general?
Yes, in FSGS.
In FSGS, okay. First, when to think about genetic study, 3 points. First, a patient who is not full-blown nephrotic syndrome. Is not severely hypoalbuminemic, not severely edematous, just the proteinuria, even if the proteinuria is in nephrotic range, but with no severe nephrotic syndrome. Second, if there is positive family history in other members of the family. Third, if there is absence of potential secondary causes of secondary FSGS. So those patients are the patient who should undergo genetic study. Although the value of genetic study is not clinically so much beneficial because they are not going to be precluded from transplantation. On the contrary, they do good on transplantation. The recurrence rate is lower than the primary. So they are not precluded from transplantation. And there is no added
this question
benefit.
is not related to transplantation. It's just in the general practice, not for transplantation. I mean,
yes. I mean. So what's the benefit? What's the benefit of knowing that they have a genetic background? It's one of 2 things: whether the recurrence after transplantation is high or not, and the other thing, whether you're going to give immunosuppression or not. So if the patient actually is doing fine, and he doesn't look to be heavy nephrotic syndrome, so we are not going to treat by immunosuppression on any account. So clinical background of the patient and presence of family history and absence of obvious secondary etiology is enough to diagnose possible genetic etiology, and the candidate genes are one among 50 at least known genes so far, and maybe difficult to interpret. So I asked about this in the States. Even in Cleveland, Ohio, they don't use to do genetic testing. There is only like 2 centers in the States, one in Mayo Clinic and one in another place, where they do genetic testing mainly for academic interest, not for the patient point.
Very well. Thank you very much, Professor.
Okay,
well, I think if we have no other questions, we thank you all. And thank you very much, Professor Ahmed. Very interesting presentation. Thanks for all the attendees, and thank you, Professor Yasser and the group. And thank you very much.
Thank you,
Professor May. Thank you, Professor Ahmed, Professor Ayman Rifai, Professor Dawlat, Professor Saeed Khamis, for your share and for your nice discussion, very nice discussion. following the great lecture by Professor Ahmed. And excuse me, close this interesting session and announce about the next session, which I will try and follow our stars. My talk about the heart of the kidney in Recurrent syndrome will be next Wednesday, inshallah, 9 p.m.
Inshallah.
Thank you very much.
جزاكم الله خير. بارك الله فيك. جزاكم الله خير. وانتم السلام عليكم ورحمة الله. السلام عليكم ورحمة الله.